Now you see, when you get a patient who's got thrombocytopenia, how are you going to proceed? Because it's one of a very common presentation when you see a patient who presents in the emergency or in medical or surgical indoors. The patient CBC may show a thrombocytopenia. If you find a thrombocytopenia, how are you going to proceed? So if there is thrombocytopenia, first see if this is a false thrombocytopenia, because sometimes during staining there may be platelet plugs or clots which are formed, which spuriously reduce the platelet count. So you have to see it's true thrombocytopenia or it's false thrombocytopenia. True thrombocytopenia means that the platelet count is less than 150,000 per microliter. And if the platelet count is low, what you are going to see next is the immature platelet fraction. This is similar to the reticulocytes. When the platelets are low, the bone marrow is trying to make more platelets, so immature platelets may come into circulation. They are generally about 1 to 7% of the platelet counts. If it's beyond these ranges, it may be abnormal. So if you see a platelet fraction, that is immature platelet fraction, is high, what are the possible reasons? This can be idiopathic thrombocytopenic purpura. It may be isolated autoimmune disorder. It may be part of some other connective tissue disorders. For example, maybe in SLE there is thrombocytopenia. So generally when there is high platelet fraction, this generally means it's idiopathic thrombocytopenic purpura. And then it can be part of other systemic conditions. For example, patient may have thrombocytopenia when there is consumption, for example in this thrombotic thrombocytopenic purpura, the hemolytic uremic syndrome, disseminated intravascular coagulopathy, patients who got hypersplenism, and some of the patients may have thrombocytopenia when there is significant blood loss and the bone marrow is trying to compensate for that loss of platelets, and more platelets may appear in the circulation. And then patients who are having bone marrow recovery, for example after chemotherapy, or patients who had bone marrow transplantation. And in some patients who've got congenital conditions like macrothrombocytopenia, this may be associated with high immature platelet fractions. So these may be the general reasons why the patients have thrombocytopenia, and you can find out if the immature platelet fraction is high, it can assist you in making a diagnosis. And then if the IPF is normal to low in patients who got thrombocytopenia, then look for bone marrow suppression. This may be aplastic anemia, or there may be bone marrow infiltration, or maybe it is drug induced, for example chemotherapy. And some of the infections, some of the viral infections, a few of the bacterial infections, they can cause thrombocytopenia. And then you see the deficiency states can produce thrombocytopenia: folic acid deficiency, B12 deficiency, and in some patients even iron deficiency can be a reason for thrombocytopenia. So now when you see a patient with thrombocytopenia, see if there is immature platelet fraction falling or going up. If the immature platelet fraction is high, that means the bone marrow is working and the platelets are being destroyed or consumed in the periphery, while if the immature platelet fraction is low or normal, this means the bone marrow is not able to compensate for the loss of platelets. So it means the bone marrow is not properly working, which may be aplastic anemia or bone marrow replacement or drug or whatever. So this is how you evaluate a patient who comes with thrombocytopenia.